Good morning, everybody, and welcome to day 2 of the Peggy Lillis Foundation for C. diff Education and Advocacy's sixth annual C. diff Advocacy Summit. Our first day on Tuesday had an amazing lineup of speakers and presenters, and today is no different. Our keynote speaker, Tessa Miller, is an incredible writer, journalist, and C. diff survivor. Following Tessa, we will have 2 breakout sessions, one about how we can educate the community about antibiotic stewardship, and the other is on C. diff infections in pediatric patients. Then at 12 p.m. Eastern, we will have a first-of-its-kind roundtable, Ask an Advocate Anything. 2 C. diff survivors and a family member will be taking your questions to understand more of what it's like to battle the disease, and also what it's like to be a family member of somebody battling the disease. Then at 2 p.m. Eastern, we have another great panel on how we can improve the interactions between clinicians and C. diff patients. Over the years, we've heard from many patients that don't feel seen or heard by the healthcare system. We will have three of them, along with a doctor and a nurse, in a conversation about this important issue and how we can do better. And our final panel discussion at 3 p.m. will be about the unmet treatment need for C. diff patients. We have a stellar group of experts and clinicians who are going to dive into what treatments are available, what gaps exist, particularly for patients with recurrent C. diff, and what treatments will likely be available in the future. As always, we are incredibly grateful to all of the sponsors of this year's summit, including Pfizer, Merck, Sirius Therapeutics, BD, DNOF, Vedanta Biosciences, the Pew Charitable Trust, Summit Therapeutics, Dalvolterra, and Hill Scientific and Public Affairs. In addition to these generous partners, I want to thank this year's lead summit sponsor, Ferring Pharmaceuticals. So I'm really pleased to introduce our Thursday keynote speaker, Tessa Miller. I first read part of Tessa's story when my colleague Bernie sent me an article about that was in the Daily Beast. And I hear your dogs are making themselves known. Tessa's work focuses on chronic illness, disability, and health justice. Her writing has appeared in the New York Times, New York Magazine, Self, Medium, Health, Refinery 29, Wired, and the Daily Beast, among others. She was a senior editor at Lifehacker and the Daily Beast. Tessa's critically acclaimed debut book, What Doesn't Kill You: A Life with Chronic Illness, Lessons from a Body in Revolt, is available now. What Doesn't Kill You is part memoir about her life with an incurable disease and part guide for newly diagnosed chronic illness patients and the people who love them. Tessa was born in Idaho and grew up in Oregon, Iowa, Minnesota, and Illinois. I have stayed right here in New York the entire time, Tessa. She's a graduate of Northwestern University in Evanston, Illinois. Tessa has lived in New York City for 10 years and resides in Brooklyn with her husband, a recent law school graduate, right? So we're excited for him. Public service law, so you guys are going to make a lot of money.
Just rolling in it.
Yeah, I know. The nonprofit executive here. And they also live with their 4 dogs, who you may have just heard a minute ago, Gixxer, Lady, Fievel, and Dolly.
Yes.
Wow. Those are some names. So you can follow Tessa and the dogs on Twitter and Instagram at Tessa Jean Miller. Tessa, thank you so much for your incredible book and for all your efforts to help people understand what it's like to live with a chronic disease and what it's like to battle C. diff. I have read your book and it touched me greatly. We will be posting links for people to buy the book throughout your throughout your remarks. And I think something that you have brought to the fore, which is just so critical, is the mental and emotional impact of living not just with a chronic disease, but also with an acute disease like C. diff. So I'm so glad you're here today, and thank you so much for taking the time to be with us today. So everyone, virtually welcome Tessa Miller.
Thank you so much, Christian. Hi, everyone. I just want to thank you all for being here with me this morning before I get started, and to thank Christian for that wonderful introduction. If at any point you want to get in contact with me after this presentation, if you check out my booth in the expo, that has my contact info. But it's also on a slide here, and our wonderful tech manager, Carl, is going to switch my slides for me. So Carl, if you'll go to the next slide, please. My contact info is on the bottom there. That's also where you can follow me on social media. And to explain the photograph that's here, because of COVID, I didn't get to do a proper book tour. So I built this mini bookshop where I pretended to have a book tour. And that is what's in that picture there. Carl, if you'll go to the next slide, just really quick. Of course, I have to show off some of the nice things that critics said about the book. I won't leave that up for too long. All right, let's go to the next slide. So my presentation today is going to have 3 parts. The first part of the presentation is going to explain my personal C. diff story. The second part of the presentation is going to explain what medical PTSD is. And the third part of the presentation is going to talk about the overlaps of medical PTSD and C. diff. I do just want to give a quick content warning here that this presentation does talk about hospitalizations. It talks about bowel disease, fecal transplants, as well as post-traumatic stress. So if at any point any of that is triggering to you, please feel free to take care of yourself first and either mute me or take a second. It's not going to personally offend me. I just want to make sure that you take care of yourself. Okay, Carl, let's go to the next slide, and we're going to hang out on this one for a second. So at the end of 2012, I was home visiting my family in Illinois over the Thanksgiving holiday, and I was hospitalized and diagnosed with Crohn's disease. Crohn's disease is an incurable inflammatory bowel disease that causes my immune system to attack my digestive system. And I've explained it before as sort of my body's repeated attempt to birth my own intestines. I know that's not a very graceful explanation, but that's about as close as I can get to telling you what it's like. If you've ever seen the classic movie Alien, which explains the photo choice here, my favorite bit of Crohn's trivia is that the guy who wrote Alien, the screenwriter, actually had Crohn's disease. And he wrote the infamous scene where the alien bursts out of the guy's body as sort of his ode to what it's like to live with Crohn's disease. So if you watch that movie now, you'll notice that that alien looks suspiciously like intestines. Crohn's disease, like so many other chronic illnesses, works in patterns of flare-ups and remissions, and no one is really sure what causes either, although there are several theories, and the treatment that works from patient to patient really varies wildly. I have thankfully enjoyed a 3-year-long remission after many years of hospitalizations and failed treatments. And that's thanks to a biologic infusion medication that I take every 6 weeks. Crohn's disease can cause a bunch of scary and painful stuff, which I have listed here. It also increases the risk of digestive cancers. And to get back to why we're here, it also increases the risk of death from C. diff. Okay, Carl, let's go to the next slide. So I acquired C. diff for the first time during that first hospitalization in November 2012, when I was initially diagnosed with inflammatory bowel disease. I was 24 years old. And a month later, in December 2012, I was re-hospitalized, and that's where I first tested positive for C. diff. I was started on vancomycin, which at that point in time was $2,000 per course before my health insurance kicked in. And thankfully, I was employed at Lifehacker at that time and had very good employer-provided health insurance. So I was really sick then, but I wasn't all that worried because doctors at that point told me this usually goes away with one round of antibiotics. And not knowing any better, not knowing really anything about C. diff at that point, I believed them. So on Christmas Eve 2012, I was discharged from the hospital to my mom's house, and I spent the following days taking vancomycin and bleaching the toilet obsessively because I was terrified of getting anyone else in my family sick. So as that round of antibiotics came to an end, I decided to travel back to New York because I thought that I was almost recovered and I needed to get back to work. But back in New York, only 4 days passed and I landed in the emergency room with a recurrent C. diff infection. And the doctors started me on another course of vancomycin. 2 weeks later, back in the hospital, positive for C. diff, another course of vancomycin. C. diff thrives in guts that are already compromised. And mine at that time was full of active Crohn's disease. So it created all these nooks and crannies for the C. diff bacteria to basically hide and multiply. So an infection that's already difficult to treat, even in a healthy gut, became nightmarish in mine. Thankfully, I was connected to a very kind, very capable gastroenterologist at Weill Cornell in Manhattan. And she was extremely up to date on research about C. diff. And she was the first to suggest a fecal transplant should I continue to fail antibiotics. She could also see that the vancomycin obviously wasn't working for me, so she switched me to fidaxomicin, which at that point in 2013 was $3,500 for 20 pills. From January to March of 2013, I basically just hung on for dear life through what I've now nicknamed Lost Winter. I really didn't do anything except go to the bathroom, sleep, take fidaxomicin, and take taxis to and from my doctor's appointments. But the doctor's appointments and those taxi rides required me to take massive amounts of anti-diarrheal medication like Imodium so that I wouldn't have accidents in transit. And as you probably know, those sorts of medications are really dangerous for people with C. diff to take because it just holds the bacteria's toxins in your colon for a long period of time. So sometimes I just wouldn't go outside for weeks on end. And at 24 years old, I really wondered if my life would be anything except going to the bathroom, going to the doctor, and being bound to my bed. By the middle of March that year, my gastroenterologist could see that I was rapidly deteriorating and that I needed a fecal microbiota transplant, or FMT. I'm sure some of you are already familiar with fecal transplants, but if you're not, I'm just going to quickly explain the science. It's a really simple idea, actually. Stool from a healthy donor is transplanted into the gut of the unhealthy person with C. diff. And that's done via colonoscopy, endoscopy, sometimes nasal gastric tube, and most recently, these really amazing freeze-dried stool capsules. I had my transplants done via colonoscopy, which is usually the most common way. So what happens in a successful FMT is that the flora from the healthy stool populates the unhealthy gut with diverse bacteria. It overtakes the C. diff bacteria and it rebalances the microbiota of the gut. It's a relatively cheap, pretty simple, abundant, and highly effective treatment against C. diff. Between 80 and 90% of recipients recover with one fecal transplant, and that goes up higher with more than one fecal transplant. Some patients require a series of them. Meanwhile, between 20 and 35% of C. diff patients will fail antibiotic treatment, and of those, 40 to 60% of them, like me, will experience a recurrent C. diff infection. So despite this, fecal transplants are still really considered sort of the last line of defense against C. diff, and that's for two main reasons. The first reason is simple capitalism. It's much easier for drug companies to make Vanco and fidaxomicin exorbitantly expensive than it is for them to patent and profit from human stool. And the second reason is that doctors know exactly what's in something like vancomycin or fidaxomicin, whereas stool has tons of variables. There's bacteria and viruses and fungi and protozoa. And so doctors have to decide if performing the transplant outweighs the risk of not performing the transplant. So my first step was to find a donor. And my gastroenterologist told me that I needed to find a donor who was my same sex, close to my age, under the age of 65, generally healthy, and had not taken antibiotics in the last 6 months. So as my family and I sort of ticked off these boxes, we quickly realized that the only candidate was my niece, Zoe, who was 9 years old at the time and would become the youngest donor in the history of Weill Cornell's fecal transplant program. Zoe really carried a burden heavier than any 9-year-old should carry. She had to get blood and stool tests to confirm that she could donate. And then she had to fly to New York from Illinois with her mom, who's my older sister, and her grandma, who's my mom. She would have to take, forgive me, the most important poop of her life, have it collected, taken to the hospital, mixed with saline, and transplanted into my large intestine. She was understandably scared of the whole process, but most of all, she told me she was scared that she wouldn't be able to save me. I had to gather supplies before the fecal transplant, and that included colonoscopy prep, Imodium to hold in the transplanted mixture as long as possible after the transplant. And if you're wondering why that slide has a photo of a blender on it, I had to buy a brand new blender. And this is because hospital staff requested that you bring the sample in a blender so they could cut down on their own handling and the ick factor of the whole procedure. Weill Cornell now uses stool from a stool bank called Open Biome, which some of you are probably familiar with. So for the past several years, they haven't needed you to find a donor or bring in a blender, but in February, Open Biome announced that they're actually winding down operations at the bank. And that's mostly because of COVID and the extensive testing that's needed. to see if stool is carrying COVID and transmitting it. And so the need for a donor and a blender could soon return. Carl, next slide, please. The doctor spent about an hour doing the fecal transplant procedure. And the morning after, I felt stronger somehow. I was hungry for the first time in months, and that just continued to improve over the next 48 hours. My taste for food fully returned. My pain started to decrease, and miraculously, my bowel movements began to solidify. FMTs work not only consistently, but quickly. Although the research that we have shows that after a transplant, the gut's microbiota is adapting and changing for months, symptoms can often remedy within days, as they did for me. And even though my doctors told me that I was at risk for a recurrent C. diff infection, I buried that warning very far in the back of my mind, unable to really think about going through it again. But 2 years later, C. diff, it did come for me again. And this time it brought me very close to death. Next slide, Carl, please. So I went to the emergency room in March 2015 with what I really hoped was just a bad Crohn's flare without C. diff. I was really, really sick, and my mom flew from Illinois to New York to be at my bedside in the hospital. Shortly after she arrived, a nurse came in to deliver the news that I indeed was positive for C. diff. And I opened my mouth to say, I understand, to the nurse, but instead of words coming out, I was just sobbing and screaming no and rocking back and forth. It took me a very long time to calm down. But when I did, I immediately started asking about a fecal transplant. Doctors at that point had started me on IV vancomycin, and I was pretty adamant that that was just a Band-Aid and that I needed a fecal transplant. And I would ask any doctor or nurse who came into my room about how we could make that happen. But in 2015, things were a little different than they had been in 2013. And that was because the FDA was regulating fecal transplants more strictly than they had been before. Under 2015's guidelines, most FMTs could only be done in a clinical trial setting. So when my lead gastroenterologist called doctors that he knew that had performed fecal transplants, they all said that their programs were either paused or just indefinitely canceled. So March 2015 turned into April 2015, and we were still no closer to getting me an FMT. Now, I understood the professional fear of challenging a government agency like the FDA, but I was also 26 years old, and I was dying from C. diff, and it felt like no one wanted to help me get the thing that I knew I needed to not die, and that was just incredibly lonely. So April became May, and I became too weak to walk. I weighed about 90 pounds, and my skin turned gray. I couldn't have anything by mouth, so all of my nutrition came via IV, and I required anticoagulant shots as well as compression devices on my legs, because when you're bedbound, your risk of blood clots increases. On a good day, my blood pressure was 70/50, and some days it wouldn't register at all. Now, at just the right time, a new hero enters this story, and that is Dr. G. Dr. G knew my gastroenterologist from years prior when they had worked at the same VA hospital at the same time. And Dr. G, just 2 weeks prior to my doctor calling him, had left the VA and taken a leadership position at Columbia's IBD program, where his research focus was and still is fecal transplants. Had he stayed at the VA, I never would have been eligible to see him. So the timing of everything really lined up perfectly. Because of Dr. G's relationship with my doctor, he agreed to essentially bypass the FDA and perform a fecal transplant. But we had to work really quickly, and there wasn't enough time to ask Zoe to come to New York to be my donor, nor did I want to ask her to go through that again. So my partner at the time became my donor. Now, the planning of this transplant was so rushed that when I arrived to the hospital via ambulance from the hospital where I was staying, there was no anesthesiologist scheduled, and I spent the first half of the transplant screaming and crying in agony until a very charitable nurse injected my IV with some kind of strong sedative cocktail that I am very thankful for. Remember, my large intestine was not only ravaged by months of C. diff, but I also had months of an untreated Crohn's flare, and we couldn't treat the Crohn's flare until we got rid of the C. diff. So my colon was just not in good shape. For 3 days following that transplant, I showed signs of improvement. But on the 4th day came fever and vomiting, and on the 7th day, my symptoms had all returned, and I, of course, tested positive for C. diff. So we had to do another transplant, and this time Dr. G promised that I would be asleep from the start, which I was. When I woke up from that second transplant, things just felt off. My belly was frighteningly distended, and there was a swelling feeling throughout my abdomen. By nighttime, I was feverish and vomiting, and the doctors ran a very fast series of tests and scans that revealed what they called a translocation of bacteria, which had led to sepsis. So basically, my colon had been in such bad shape that the second transplant caused E. coli to leach into my abdominal cavity. Next slide, please, Carl. But somehow, thanks to 4 times a day antibiotic infusions, combined with whatever good bacteria had sort of stuck from the fecal transplants, I slowly started to feel better. And over the following weeks, my blood markers improved, my appetite started to come back, and my pain decreased. So I was able to go home on June 10th, 2015, and the very next day I had my first infusion of infliximab, which is the biologic medication that manages my Crohn's disease to this day. Over the next few months, my body took a long time to heal, even with the right medication. My legs were so weak from months of being bedbound that I fell down a lot. I lost half of my hair thanks to the new medication, as well as a phenomenon that my doctors explained happens after stress or trauma that basically shocks your hair into shedding. I needed prescription weight gain shakes because I was so skinny. And pain still radiated through my abdomen for several months after. But still, my doctors called my recovery, quote unquote, miraculous. All right, let's shift gears and go to the next slide. So this is part 2 of this presentation. We're going to talk about medical PTSD. Medical PTSD, which is also called illness-induced PTSD, is really under-researched. But here's what we do know about medical PTSD. It affects up to 25% of people who've gone through a life-threatening medical event. And it's especially prevalent in people who've had cancer, heart attack, stroke, spent time in an ICU, people who've given birth, and people who deal with inflammatory bowel disease. So especially relevant to my personal story is that 40% of people who have medical PTSD attribute it to a digestive disease, and that's most often inflammatory bowel disease. So people who felt acute danger during their medical event, or people who feel like they don't have control over an ongoing chronic condition, are at higher risk of developing medical PTSD. Essentially, any event that puts you at risk of death or poses serious danger to your body is really going to shake the way that you see the world as balanced and fair, and also how you see yourself as invulnerable or even immortal. And that just really shakes the way that we see ourselves and our place in the world and our relationships with others. So I also want to just make this highlighted part clear, and that is that medical PTSD can arise not just from the event itself, but how you were treated during the event. So if you were treated badly by by hospital staff, if you were felt neglected, if you were repeatedly misdiagnosed or mistreated, that increases your risk of developing medical PTSD. Now, it's important for me to highlight here that I have privilege and really power in the ways that I'm able to navigate the American healthcare system. Being white, being cisgender, being thin, having health insurance, and most of the time I'm able to move through spaces without mobility aids. And I'm still afraid that I'll be misdiagnosed or mistreated when I interact with medical professionals. Now, others aren't nearly as fortunate as I am and often have to deal with biases, often overlapping ones, especially race, weight, gender identity, that greatly affect their health outcomes. And the COVID pandemic has just really illuminated what we've always known to be true in the American healthcare system, and that is that Black and Brown communities are suffering more than white communities. I also just can't go through this presentation without mentioning the intense fear of how much medical care costs here in the US, which research has shown time and time again prevents even people who have health insurance from seeking care when they need it. My infusion medication, which I mentioned prior, is billed every 6 weeks at $70,000. So you can imagine how fearful I am of losing my health insurance. And it's not just patients who suffer in our system, it's doctors too. They work in highly stressful conditions. They have to churn through patients because that's what's demanded of them. They graduate with insurmountable amounts of student loan debt, $200,000 on average. So it's just really no wonder that in a system that isn't adequately serving patients or physicians that medical PTSD is prevalent. Next slide, please, Carl. So the symptoms of medical PTSD are listed here, and I just want to explain the two which might not be familiar to you, and that is hypervigilance, which is simply feeling like you're constantly on guard, and catastrophizing, which means that you immediately expect the worst to happen. So say in a C. diff survivor, they might have abdominal pain or changes in their bowel movements, and immediately they think, I have C. diff again, and it's just going to be the worst that it's ever been. In more traditional PTSD, the triggers are usually external. So in therapy for that PTSD, the focus is on safety in the present moment and distance from what happened. But in medical PTSD, the triggers are often from the person's own body. Like I said, for example, with C. diff, maybe abdominal pain and changes in bowel movements. And so learning to cope with these more internal somatic triggers, which for chronically ill people like me can last a lifetime, is more difficult work. Now, some of what we know about medical PTSD comes from adult survivors of childhood cancers. And according to research from the University of Pennsylvania, about 20% of adult survivors of childhood cancers report ongoing PTSD. Some of their symptoms didn't show up for years or even decades. So this is important. Symptoms of medical PTSD, if untreated, can grow stronger over time rather than diminishing. After my months in the hospital with C. diff in 2015, my own PTSD showed up as hypervigilance, heightened anxiety, insomnia, and a lot of replaying moments where I wasn't sure if I was going to make it. Several months after I was discharged from the hospital, I walked past it on my way to a bookstore. And as soon as I walked past the hospital's entrance doors, I abruptly vomited all over the sidewalk. Now, my symptoms weren't always so dramatic, but I was irritable and scared really all of the time. Even after years in therapy, learning coping mechanisms for PTSD, I still deal with its effects. So last December, I came down with a kidney infection, which I knew would require a trip to the emergency room. And I also knew that kidney infections need antibiotics to be treated. So I knew that I needed to go. But the thought of going to the hospital, this place where I had received life-changing diagnoses, where I had languished for months with C. diff, and now a place that was overburdened by COVID, it just felt crushing. And my brain just immediately went back to 2015, and I just kept thinking, what if I get C. diff again? Thankfully, my husband was here and really encouraged me to go to the emergency room and sort of served as my advocate while we were there. And I received excellent care, by the way. But had he not been here, I might not have gone at all. That's really how paralyzing the fear was. And that's when medical PTSD becomes dangerous. Next slide, Carl, sorry. Medical PTSD becomes dangerous when, in an attempt to forget what's happened to them or to prevent it from happening again, patients will avoid the care that they need or the medications that they need. In a Columbia University study that looked at heart attack survivors, they found that medical PTSD doubled the risk of dying from a second heart event 1 to 3 years after the first one. And the researchers suggested that this could have been because patients were avoiding the medications and care that they needed due to fear and anxiety. For myself and fellow chronically ill C. diff survivors that I've spoken to over the last decade, many of us put off emergency care for our underlying conditions because of our fear of C. diff, and that results in our underlying conditions worsening and often becoming harder to treat. Next slide, please. So C. diff is sort of the perfect recipe for medical PTSD. And that's because it feels like you can't control it when it happens. It feels like you can't control when it happens again. It feels literally and figuratively isolating. It turns places where you're supposed to go to get medical care, where you're supposed to go to feel better. It makes those places frightening. It also makes common medications like antibiotics, which many of us are going to need unavoidably at some point. It makes those frightening as well. And so it's easy to catastrophize like I did when I had the kidney infection. Some patients have to fight just to get a C. diff test and are often dismissed as having irritable bowel syndrome, food poisoning, neurovirus, hormonal changes. I've really heard it all over the last decade. And when patients are young, they're often told that they don't fit the profile for C. diff, even though we know that C. diff is increasing in younger populations. So by the time they're properly diagnosed, the infection has often worsened. For patients who need but can't access a fecal transplant, they often feel neglected or poorly treated, just having to fight for the care that they need. And as we've seen with COVID and the populations that are at greater risk, as Christian so eloquently explained in his keynote on Tuesday, namely chronically ill, disabled, and the elderly, C. diff, depending on the care that you have access to and how you're treated, can really just reinforce the feeling of entire populations being disposable. Despite this sort of perfect recipe for PTSD, in the overwhelming majority of C. diff survivors I've spoken to over the last 10 years of my work, mental health care was really never brought up. And most of them don't even know that medical PTSD is a very real thing. They simply think that they're going crazy or overreacting. Some of them have told me that they feel like too much time has passed from when they had C. diff for them to still be feeling the mental effects that they're feeling. But as we know, sometimes these symptoms of PTSD don't show up for years or even decades. All right, next slide, please. So C. diff patients, oh, is that slide switched for you guys? Sorry, Carl, next. Oh yeah, okay, sorry, I can't see it because it's very tiny on my screen. Okay, C. diff patients need mental health care built into their care plans from the beginning. And doctors need to tell their C. diff patients that they should anticipate feeling anxious, depressed, confused, sad, angry, and that these feelings are all valid. A referral to a mental health care professional who is well-versed in health psychology and medical trauma should really just be the bare minimum. Simply affirming that medical PTSD is not only real but normal after a medical trauma like C. diff really empowers people to seek the help that they need. I've found that just giving a name to it helps people feel less alone and more proactive. Now, education, a big reason that we're gathered here today. C. diff patients need better education about the causes of the infection and how they can mitigate risk moving forward. Again, I can't tell you how many times over the last several years I've gotten an email from someone who has been diagnosed with C. diff. They go home and they Google C. diff, and my name comes up because I've written about it. And so they reach out to me and they say they were diagnosed with C. diff, but they don't know how they got it. They don't know what their treatment options are besides antibiotics. And they don't know how to mitigate risk moving forward. I also just want to mention here that though this presentation has really focused on C. diff patients and survivors, that loved ones and caregivers can also experience PTSD, even if they didn't experience the medical trauma firsthand. Medical trauma is really kind of like throwing a stone on a pond and it just ripples outwards. So the bottom line is that while we really don't have enough research about medical PTSD and we need more research, one thing is super clear, and that is that the sooner medical PTSD is treated, the better the outcome. I'm not going to bore you here or take up more of your time with all of the research and statistics about how much therapy and mental health support can really be life-changing for people who have been through medical traumas. There's chapter after chapter about that in my book, if that is interesting to you. But I do want to make available here a list of mental health resources, either for you or for people that you're advocating for. And that is in Google Slides, in my booth, in the expo. Mental health care should just be accessible to everyone, no matter your income or if you're able-bodied or disabled. And I did my best on that list to collect the resources that make those services accessible under our current healthcare system. All right, I think we are at the last slide. Oh, yeah, okay. Now we have some time for questions and for me to show off my dogs.
Tessa, that was just incredible. We were getting a lot of comments from the survivors. Just, I think, really resonating with what you were talking about. You know, and I think in addition to, you know, what goes on for people who are either acutely ill or chronically ill, there's also family members and loved ones who
absolutely
are also dealing with our own feelings of guilt, inadequacy. You know, my brother and I made a pact after my mother died that we would never be mad at each other for not knowing what we didn't know. And,
yeah.
You know, we've seen a lot of families who, you know, there's a lot of disruption when a loved one is ill or when a loved one dies because people start blaming each other.
Of course.
Did this, what if we did that?
Yeah.
And, you know, that's so if folks have questions for Tessa, we have a couple minutes left. Please let us get to them.
And if we don't have time to get your question in now, I'll be back from 1 to 2 hanging out in my booth. So you can find me there too.
I think you might have just stunned them into silence, Tessa. Your presentation was so good.
Also, if there's a question that you want to ask privately or whatever, you can also find my contact info too if you want to reach out to me via email.
So I guess I have a question for you. I think, what do you think? I mean, you get into this in your book, and I can't encourage people enough to read it. But I think even when people receive good care and you go through this, just having your body, invaded with, I mean, I've had several colonoscopies and endoscopies, and, we're just not used to that. And there's something about our culture just kind of like, we have to be so protective of our bodies. And I think that's doubly so for female-bodied people and women. I mean, do you think that there is a connection between just the invasiveness of it, even if you're getting care?
For sure. I think that loss of bodily autonomy, really feeling like you just exist to get poked and prodded and scanned and tested, and it really sort of shifts your sense of self, and it feels like a loss. I think there's a grieving process that people go through for this sort of loss of self, and I think that loss of autonomy, which I didn't really discuss so much in the presentation, but I talk about in the book, can also lead to post-traumatic stress. That's that giving of your physical self over to medical professionals can be super triggering for people for all sorts of reasons, and is something that in itself can cause lingering post-traumatic stress. So yeah, I guess my answer to your question is yes, 100%.
So we do have two questions. Actually, three. So Helen asks, as a psychology nurse, she's seen a lot of medical PTSD. Some physicians put patients on mood stabilizers like Zoloft. Do you think medical intervention such as medication is a good idea?
I think that it can be. I mean, obviously, every individual case is going to be, a decision between you and the people who are caring for you. But I am never one to sort of pill shame when it comes to mental health. I think that, we treat our bodies and our brains are just as valid as treating our bodies. I mean, medication can be life-changing for people, but again, it's just it's an individual choice and decision. And I know, people feel anxious about even talking to their doctors about the potential need for medication. And to some people, it feels like a loss when they need to go on mental health medication. And I wish that we wouldn't think about it like that. It's just, there's a vast toolkit available to us. And we're sort of living in a golden age of mental health care. And so it's something that, absolutely some people need, some people don't. And there's no shame in utilizing the tools that are at your disposal.
Yeah, I mean, you and I have talked about this privately.
Yeah.
I have OCD since I'm a kid, and so I I take medication for that, and I see a therapist and a psychiatrist frequently. And,
Yep.
that combination, as well as the incredible support of my husband, my friends, my family, lets me do this kind of crazy job.
Yeah,
Just
absolutely.
living, with a mental illness. So we're very close to time, but let's see if we can get in a couple more questions. Gerard asks, do you have any thoughts on how to elevate voices of survivors who are not as comfortable with public speaking or don't have our visibility? I think he's referring to this as like, white folks with college degrees don't have our visibility in society, so we can capture patient experiences more inclusively.
Yeah, that's a great question. I mean, besides burning it all down and rebuilding it, I mean, I'm a huge advocate for community level organizing in all things that are political, and obviously bodies, especially ones that get sick, are highly political. So organize like at your community level, start small. Also, the internet is a really good place to not only connect with people who have been through similar things that you've been through, but also to kind of like dip your toe into how comfortable you are with talking about that stuff. You don't need to just go from zero to doing a keynote on the internet. Just like talk with people in your community, in your social circles, find support groups online, whatever. You can just like lurk in them if you want, which is what I did for several years before I was comfortable enough to talk about my own experience. Sometimes just writing it down can even feel empowering. But yeah, comfortability with talking about this stuff is a very incremental process. I think it's not always just going to be, that you're suddenly comfortable talking about it. I mean, the first time I wrote about having C. diff, as I wrote in the book, I was absolutely terrified. So it also doesn't always feel good at first. But I think that the work of telling these stories is important enough to keep doing it.
So we do have a few more questions. So I'm going to save those for you and actually share them with you for your meet and greet later. Maybe we can address some of them then.
That sounds good.
We do have to go because we have other panels starting in a couple of minutes. Tessa, I can't thank you.
I won't take up any more of your time.
No, honey, you have been amazing. Oh, I just gayed out there. I'm like, okay, honey. But thank you so much. I have really appreciated you being part of this. I think it was a huge boon to so many people that have not had the opportunity, or your platform to speak on this critical issue. And I'm looking forward to finding ways for us to work together to continue to raise visibility about this and help.
100%.
I think that's really critical. So thank you so much. Please check out her booth at 1 p.m. And right now we are actually going to go to a video from our board member, Christina Furman, talking about her C. diff experience as both somebody battling it and as somebody who had a child battling it. And after that, check out the breakout sessions, one on pediatric C. diff and one on being an antibiotic steward in your community. So thanks again, Tessa. We'll see you soon.
My name is Christina, and I'm from Columbia, Missouri. When I was 31 years old and engaged to be married, I had my whole life ahead of me, and all of that came to a screeching halt when I contracted C. diff, which I had never heard of. I was in the hospital 6 times over the course of 7 months without food, not able to drink. I could hardly stand. Antibiotics are used to treat this infection. However, the antibiotics for me were completely ineffective. And the only reason I recovered was because of an alternate treatment, which is the fecal transplant. And if that hadn't been available, I would have surely died. A year after my recovery, I became pregnant with my daughter Pearl, and I gave birth to a wonderful, healthy little girl. But by the time she was 2, she started becoming sick as well, and it looked familiar to me. It looked scarily familiar to me, and she was diagnosed with a C. diff infection. But thankfully, the Mayo Clinic also performed a fecal transplant on her, which of course saved her as well. When I found the Peggy Lillis Foundation, I found people that had suffered just like I had, and people that had lost loved ones. And together, there's just so much that we can do. We're attending meetings, we're educating, we're doing advocacy. We're currently working on making C. diff a nationally notifiable disease. Peggy Lillis Foundation also has a new care guide that people can look at and learn a lot more about this disease as a caregiver or as somebody that's suffering with the illness. A year and a half ago, Christian Lillis, who is the executive director, and I were invited to attend a meeting at the CDC. And we met the director at the time of the CDC. And in speaking to him and being able to share our stories, it really made me realize just what a gift, what a platform the Peggy Lillis Foundation has provided, because I could tell that we all had a story and everyone there cared about it. And this is exactly what I had hoped for when my daughter lay on my stomach. And I was terrified for both of us and for our whole little family. This is exactly what I was hoping for. And I'm so glad that the Peggy Lillis Foundation is around to help.